Hello again, my fellow coders and my lovely providers. Welcome to another one of my videos. Today we're going to be talking about drug addiction codes in pain management. I think it's a huge epidemic. I could train a lot of different providers, talk to a lot of different bodies, and even other coders. And everyone has a lot of issues with drug codes. So I want us to work on them all together, teach everyone how they should be done. I have a lot of infographics throughout here. Everything in my video is free to share, free to use. Go ahead, share this video with your team at the next all staff meeting. If you work in a population where you have a lot of drug users or something like that, I personally work at a FQHC, so really important codes to me. So important that everyone understands how they should work. So let's strap in, have a fun video, and learn how to code these ones. So where we're going to start this video off here is with the Z79 codes. Because the Z79 codes are more or less your RX versions of codes that providers seem to mistaken and not think of as often. The Z79s are your long-term and, in parentheses, current drug use codes. The reason why we say long-term and the current in it is if you have like a diabetic and you're just starting them on a metformin that day, but they're going to be on metformin for probably at least a year or 6 months or maybe indefinitely, you would still assign Z79.84 to indicate that your patient is on that. But the code I want to talk about and where the mistakes get made the most often is this code here, Z79.891. Long-term current use of opiates. This is the main code that you're supposed to actually use whenever you're dealing with a patient who's on any pain management. So what happens is people tend to mistake in these codes. So let's break down the Z79 a little bit further. The Z79 codes are used for like prophylactic use, long use for all these different kind of medicines. I did generate everything with Gemini. I know AI is a little crummy at times, but frankly, all these things are beautiful, and I'm really happy with them. I did have to correct quite a few slides, so sorry if it's ugly at times. Sorry I missed this VE26, but actually I kind of liked it and thought it was funny. But basically how these Z79 codes work is you use them for the long-term medicinal use. You do not use a Z79 for a drug addict. That's the key note here, is Z79 aren't drug addict or drug addiction codes. The reason why we clarify that word, that these aren't the drug addiction codes, is because the F10s through F19s are drug addiction codes. So what will commonly happen is providers will assign this code here, opioid dependency, F11.2, when we're talking about a patient who's been on painkillers for maybe 10 plus years now, or maybe 5 years after a car accident. Providers, I get where they're coming from, where the patient is dependent on the opioids because they've been on them for so long now. But really, that is improper to say. So let me kind of point it out this way. These codes are long-term. So keyword long-term. What do we know about RX medicines? Of course, dependencies are going to happen. So that's kind of an expected result of most medicines. I'm on SRIs myself, and I can't just quit those because I am dependent on them at this point. But it would be inappropriate to assign an F dependency code to me because I am stuck using those. And then the same thing goes for use. Use is in the medical words already. So use is implied in itself. So when we're talking about using medicine for pain management, you're supposed to use a Z79.81. So I have here, it's if you want to report someone who's on medicinal opiates, but they are abusing their meds, that is when we can use abuse. That's the key thing here, is these codes all exclude each other when it's the use version or when it's the dependency version. As you'll see, the .9 versions are for use and .2s are for dependency. But abuse can be reported with Z79.891. So that's how you're supposed to do it. So let's say you have a patient who has been on painkillers for 10 years and they do abuse it and they do have a drug addiction problem. then it would be appropriate to report that they are abusing their prescription medicine, but also stating that they are prescribed them. So just remember this. If you're using F11.2 to indicate one of your pain patients is on opiates for a long period of time, that's really bad. You're actually indicating that this patient is an addict. So let's break it down further with how the codes show it. Is the codes each exclude each other, and as I've mentioned already, abuse is just fine to go with these long-term drug codes, because long-term dependency is going to happen. Use, obviously use is going to happen. So that's why they're counterintuitive to each other. A patient can only abuse their prescription medicine. So just make certain you're indicating that when you have a patient on long-term pain meds and maybe they're on it for 10 years and they are dependent because they were put on Dilaudid or something like that a long, long time ago, they will still be this medical version of the code. They are not the drug addict. To expand more further on this is when you're using the opiate use disorder code, you have to be following the DSM-5 model when it comes to this. There are 11 different categories that we're not going to fully break down, but all these slides will be available to review, that this indicates the status that a patient is at. How they have it is 2 to 3, we're going to be in the use category. 4 to 5, we're going to be in dependency. 6 or more, we will be in dependency as well. So that's how it works. So when we're dealing with a medicinal patient who's on long-term opiates and you as a provider assign F11.2, you are indicating the patient has at least 6 of these categories going on. So you're saying the patient has craving, substance seeking, continued use, social avoidance, when usually it is just plain the patient is on long-term pain management. So really, you gotta be careful with this as a provider. So I want all providers to be aware of this. Note when we're counting the criteria, tolerance and withdrawals cannot be counted towards a patient who's on medicinal use of it. So when you're trying to calculate whether or not a patient is abusing their medicinal medicine, just make certain you're not counting tolerance, because obviously tolerance is going to go up with long-term use, and withdrawals is obviously going to happen when you reduce or something like that. If you switch them over to Suboxone or something like that, they are obviously going to have withdrawals. So just make certain you are reporting your codes right. So these are the F10 through F19 family of codes. These are all drug abuse, drug use, drug disorder codes. This is how all these codes work. So when you're saying your patient has dependency on opioid, just keep in mind you are putting them in this whole family here. So just be certain you really want to indicate that that patient is actually an addict or not. So I have plenty of the drugs broken down here. One of the ones that I'm curious about and we've looked into quite a bit with my team, and man, Dr. Mike, if you decide to watch my video and decide to share the whole thing, I would love it. I know you work for an FQHC, so I bet kratom is a big issue for you. Having a hard time identifying exactly which category kratom should go in. I have read a lot of medical studies that they are considering it an opioid because it breaks down the same way as an opioid in your brain. But hey, I would love it if you went bee-whoop and you told me what you thought kratom was and which category you would go with. I do think it might possibly just fall under this F19 other drug. This is the one appropriate time to use these F19 codes. We're going to expand on that quite a bit further there. But basically how these codes work is they're actually really easy. They're each broken down by their own drug families, like F15, other stimulants is where you'll find methamphetamines, and then you'll have the category here for what status level your patient's at, and then finally what kind of complications they have. It's actually pretty easy. I got broken down by opioids, because that's going to be the common one and the main thrust of my video here. And then on the side here, I have the with guidelines listed out. What I want people to know is the with guidelines, how they work in coding, is they are coded as related even without explicit provider linkage. The reason for that is everything with a with, when it comes to coding, has a causal relationship, is how it's expected. So, for example, if you have an opioid addict or an opioid abuser coming in and they're complaining about hallucinations, and we don't know the exact cause of their hallucinations yet, whether or not it's schizophrenia or something like that, it is actually proper to say that they have hallucinations due to their opioids, because we're really not certain at that point and they have a causal relationship. If your patient comes in complaining about not being able to sleep, and we're not certain yet whether or not the patient has like OSA or something like that, we would indicate the patient having this with disorder of their opioids. Their opioid addiction is giving them a sleep disorder. Keyword that I keep dropping though, remember, I'm using addiction every single time here. If you have a patient who is on long-term medicinal, Z79.81, and they're coming in complaining about erectile dysfunction is a common side effect of opioids. In that case, you would still just use the drug-induced erectile dysfunction code with the Z79.891. It would be inappropriate to make it the sexual dysfunction due to opioids, because this is an opioid abuse causing sexual dysfunction, or opioid dependency causing it, or use causing it. So I want to be clear with that. You use these codes when we're dealing with an addict who are suffering from one of these problems and we don't know the explicit cause for them yet. Keyword documentation has to be explicitly stated that conditions are unrelated. The reason for this is your coders will probably get a denial for why do you have F11 abuse with insomnia on the side and you don't have it combined with a sleep dysfunction. What we'll do is then we will send the record your actual chart with it that explicitly has your wording stating how you know they are not related. So make certain you are very clear when you know for a fact that the conditions aren't related to each other, so they do get properly separated. But otherwise, when we're dealing with a drug addict with one of these conditions going on, it is safe to assume that the drug is causing these conditions. So now let's get to polysubstance use, F19 or other unknown drug. It's kind of the main breakdown here for this one, is these codes are set up as the main known drugs. A lot of providers like to use F19 for polysubstance use, but this is actually used when the substance is unknown, is the reality of it. These codes are for when substances are unknown, or if the substance is not classified. Once again, P-Whoop shout out. I'd love for to hear your opinion on Kratom, in which category it should be classified in, because I know our CMS and DHS is god-awful right now, and I'm not expecting any good information from them. So, frankly, drop in the comments what you think Kratom should fall under, if you think it should be at F19, or if it should fall under the opioid codes. I would love to hear what your thoughts are on these. So basically how these codes work is you do not use them when you know a specific code to use for a patient. So for example, you don't, let's move on to actual, here we go. Let's go to this slide first and then I'll use my example. So let's break down F19 as polysubstance use disorder. This is a major issue where Epic will assign it as polysubstance use disorder, because it is right that it's an approximate synonym in coding guidelines, because it is a diagnosis that polysubstance use can be used, but it is overused by providers and it's not properly used. So let's break down what polysubstance use actually is and what it means when you're using that F19 code. Polysubstance use means that the patient is on 3 or more substances, and we do not know what the predominant substance is. That's the key part of it, is we don't know the predominant substance. It's also labeled as indiscriminate drug use. So most of the time, it really isn't that indiscriminate. The drug of choice is going to be listed. So let's say, for example, we have a patient whose drug of choice is meth, and then they also will use opioids when they can't get it. They like using marijuana, and they're addicted to alcohol. that patient shouldn't be reported with an F19 polysubstance use code. Instead, the polysubstance use is going to be shown by having all of these different drugs listed. So the meth will show up as the F15 with dependency on it. Cannabis will show up with a .1 on it for the use of it. Opioids will show up with a .9 on it for abuse, and so on. That's how you're actually supposed to show polysubstance use. The poly shows up by the codes themselves. Oh, and then the F10 for alcohol ending with a .2, since I stated they would be alcoholic dependency. So this is the proper way of showing polysubstance use. It's listing each drug separately and what each of the individual drug statuses are. Polysubstance use is used when it's indiscriminate use, usually when it's early in you knowing a patient and you haven't quite figured out what their drug of choice yet is. That's when you can use these codes. But usually when you have a long-standing patient, it is best practice to use the more specific codes, because you do not want to use these when we know a more specific code. So key requirements, you can use it when it's not known and when the specific substance is involved. So just remember this with polysubstance use. Best practice is to actually have 5 different codes listed if you actually have such a severe drug addict that they're checking every single one of these categories. That is best protocol. And it's also best for you as a clinic too, because almost all these codes are HCC codes, and it's a really good way of showing the high level of care that you're providing. You don't want to shortcut yourself and your clinic by just using F19 as a quick crutch, when really you have a patient who has like 4 different drugs interaction going on and you're working with that patient. That's high level work that you're performing. It's only shown if you use the codes properly. If you use those 5 codes, everyone's going to know, oh wow, this provider worked really hard for this patient. They did a lot of work for them. F19, wish we knew more about it. This provider might possibly get audited if they use it way too often. F19 is the most likely of these codes to get audited. So hey, personally, I would not recommend using F19, except maybe in the actual true unknown cases like kratom and stuff like that. But sadly right now as a coder, F19 is kind of a really bad code because it's overused and abused by providers, so insurances generally deny it really way too often. So I really don't like this code at all as an actual coder trying to get payment, but I do think it would be better used as unknown if it wasn't over-reported as polysubstance use. That's my 2 cents on the documentation. Honestly, highly recommend you split those codes when you know the drug of choice and you know the interactions of each of the individual drugs. So here's a little breakdown again of how the drugs will work for categorization of it. Drugs are broken down in a hierarchy where we can only have one of the 3 statuses indicated per a patient. So only one can be assigned for it. So basically, if your provider documents all use, abuse, dependency, all 3 of them, only dependency should be coded in that case. So just be mindful of that guidelines. I then like to pull up the uncertain diagnosis guidelines, just so people are aware, because it's really important once we start getting into the remission guidelines, that we do have specific guidelines for what kind of words we can more or less trust or not that a provider uses. So if the provider doesn't actually fully state that a patient is in remission or something like that, we cannot use those kind of codes. So I just like to remind people, please always use definitive language whenever you're documenting in your record. And then you can have multiple of these statuses per a drug though. So for example, if we have an alcoholic who's dependent, he will only get the dependency. Someone who uses cannabis, he will only get the use code. And then let's say they abuse opiates, they would get an abuse on it. So that's how it would work, but instead we wouldn't have one drug listed 3 separate times. We just use the drug and its highest level, and that's it. Next, for in remission guidelines here, and just general coding guidelines once it comes to substance use, here's just another table for a way of looking at substance use, just a priority chart of it. When it comes to remission, we can only assign it when the provider explicitly states the fact that the patient is in remission. And then how remission codes work is we will assign the code status based off the highest severity status that the patient was at before achieving remission. So let's say the patient only abused their opioids at the time, it will end up being this .11 family. And then if it was dependency, it will be a .21. Easy way to remember remission codes is that always ends with the 1. 1 is the ending for every single drug code when it comes to the remission, and then I've already broken down use and abuse. This guideline here is important that a lot of providers will tend to miss, is the medical condition due to substance uses. So we do have guidelines for when you have a medical substance use caused by their drug use, make certain both codes are reported at the same time. So one of the examples that the book uses is when we're dealing with an alcoholic who has pancreatitis, it is the proper to report both the alcohol dependency and the pancreatitis with each other, so in that way it's clearly indicated in this patient's record that one more than likely caused the other, or they are at least related. Oh, I guess absolutely caused, because it's the alcohol-induced pancreatitis code. Next to the documentation guidelines. Documentation guidelines is here's each of the categories for how each of them work for the codes. Basically, we all know what dependency, abuse, use is. The important part that I want to make certain everyone get out of this is use the Z79 codes when we're not actually dealing with an addict. Don't use polysubstance use if you actually know the drugs. And finally, make certain you're documenting physical and emotional symptoms from it, because that is something that's commonly missed. Oops. Oh, I mean to grab my noodle. There we go. Sorry about that. Main one I want to talk about for the providers is these bottom guidelines here for the clinical documentation checklist. When it comes to these codes, I took these guidelines from the CDI current guidelines here, where you must obviously name the drug that your patient is using. You must also list the level that they are at in your documentation. You must also state the clinical state of it, whether or not it's uncomplicated, intoxicated, remission, or in withdrawals. Once again, your coding team cannot use the code remission unless you as the provider explicitly state that this patient is in remission. So i.e. you say, I am dealing with a patient who had a sedative abuse problem and it is in remission. Now your coders can use it. Indicate induced disorders that have come from this, whether or not they have anxiety, delirium, the sexual dysfunctions, what we were talking about before, the with guidelines. These are the with conditions that commonly happen when you abuse drugs. Indicate if the patient has one of these going on, and if so, you should actually use one of those codes for your patient and not an uncomplicated code. Prescription status, just clarify what kind of medicine is being prescribed for your drug addict. Basically, big one for this is opioid addicts and Suboxone, or a meth addict, methadone, so forth. Just make certain you're indicating the drug that they're being treated with to help with it. Plus, physical and emotional symptoms should be documented. It is best practice to document these, whether or not they have physical withdrawals, what kind of symptoms are going on. A lot of providers will document whether or not they notice tremors or difficulty breathing, that kind of stuff. Emotional withdrawals, just make certain you're indicating how the patient's mood is and such like that. And then intoxication, basically whether or not you think the patient might actually be intoxicated during that visit at that time. It's important to indicate that in your notes when we're dealing with a drug addict, because it really does show the level that they're at and let us know. Why I like sharing all of this as a big piece is what'll happen is providers might give us only individual bits and pieces of it. So let's say, for example, patient comes in and my provider note read, patient is clearly drunk, they report drinking a fifth of alcohol every single day and a 6-pack of alcohol as well. And that's it. That's all I have for it. That will give me the intoxication. Absolutely, the intoxication information's well documented there. I also know the name of the substance being alcohol, but I don't have level of use. I don't have clinical status. I don't have induced disorders. I don't have prescription status. I don't have anything else. So because of that, your coder cannot assign any of the alcohol disorder codes. You as a provider must list all of this explicitly for the patient to actually be considered an alcohol use disorder or alcohol dependency in that scenario. So just make certain you give us the full story. We have clinical documentation checklists, so do CDIs and so do auditors. So we have to work with the documentation that we have. So if we only got one of the 7 categories that need to be documented, we cannot use those conditions. So big takeaway here is be very explicit with your drug documentation. And finally, just to put a big pretty bow on everything, here are the coding guidelines and why everything's so important. Unspecified codes should be used as your last resort based off of the following guidelines. A.9.b, codes titled unspecified are for use when the medical record information is insufficient. What I really want to take on this one is we move on to the level of details when it comes to coding. Coding guidelines make it clear that we must code to the highest number and highest level of specificity possible. So when I'm talking about that F19 for polysubstance use scenario, don't use F19 if you know the drugs. Instead, report all 5 drug codes. That's what you're supposed to do. It's the proper way of reporting things. Uncertain diagnoses, just once again, I want to make certain everyone knows you've got to be definitive with your language. If you're not letting us know explicitly that your patient is a drug addict, if they have use, whether or not it's at uncomplicated levels, so on and so forth, no one can use it, and the audit is going to be failed if the record ever gets looked at. So we combine all this up. What do we get from it? We get way more accurate risk assessment scores. Kind of what I was talking about before, that's our HCC rating. It shows how big of an impact we're doing to our community. If you're only using F19 versus 4 drug codes, you're really not showing how hard your work is. Proper resource allocations, this affects funding and such like that. It makes a huge difference from it. And also on the flip side for proper resources is, let's say you do a lot of pain management patients and you're reporting all of your pain management patients as a F11.2, the opioid dependency. Technically that's fraud because those codes are HCC codes and you're getting paid a higher rate when your patient's actually just a pain management code. So make certain you're using the right diagnoses, because as you may or may not know, Medicare and Medicaid love to pay people because they review things a lot faster than everyone else, but they also love looking at stuff 2 to 3 years later and being, we want all of our money back. So I would highly recommend that we look at it from both facets. Yes, is it beneficial that you'll get more revenue for your actual polysubstance drug users and reporting it to the highest level? Yes. Do you have a lot of pain management patients and all of you are saying your pain management patients are opioid dependency and you're going to hurt your score? Yes. But that is the right thing to do. You want to report your data properly. One of the reasons why this is such a big one for me that I love so much and care so passionately about is, as you can see, I'm kind of a jittery guy and everything. So I've been on benzos in the past. And one of my providers not coding well put me as F15 benzo usage. So for years, I didn't know my record had other stimulant use on it. It's really bad when you have a drug addict code on your records for just being prescribed a medicine for 9 months. It's not good. It made it hard for me to get medicines, and frankly, it was very hard for me to get it off my record. Took a lot of battling, honestly. So make certain you're reporting things properly. So finally, what I got here is just a written form of all the information here as well for another version to look at things. This all came from Optum's most recent CDI book. The main one that I want to check off again is kind of what we discussed before, is just make certain you're properly documenting everything. If you don't document all of this information, we will not get your revenue and you will not be reporting drug addicts right. So finally, to wrap everything up, let's just look at the F11 codes again. We have everything with a pretty bow on it. You will use a .1 ending for any of your drug codes if it's abuse, .2 if it's dependency, .9 if it's use. Only use uncomplicated if it truly is uncomplicated. If the patient has any of these going on and properly documented, these codes should be used instead, and you should report your drug addicts to the highest level possible. If you have an opioid user for medicinal use, make certain you're reporting them as a Z79.891 if it's RX pain management, even if they've been on it for 10 years. It is what it is. A lot of people got screwed over by the opioid epidemic. We got to properly report how many people got screwed over by it. But to phrase them as dependent on their opioids because healthcare more or less failed them isn't fair, and it isn't right thing to do. Nor frankly is it just. So I hope you all enjoyed the video. Please like, share, subscribe. If you work for a practice, I will be sharing the slides in my drive file below. Feel free to take it. I would love for people to spread the good word about how to properly code your drug usage codes. So thank you. Have a wonderful day. And to all my providers, love you. Thank you so much for what you do.